Okay, our next speaker is going to be Maya Guglin, who's a professor of medicine and director of heart failure, cardiac transplant, and mechanical circulatory support at Indiana University School of Medicine. And Maya is going to talk about hemodynamic goals in shock management. Is there a target for all?
Good morning. Nice to be back in-person meeting. And now that I know that this thing is going to steal my slides, I better go straight ahead. So, preparing for this talk, I went to scientific statement from the AHA to the section which is entitled the Critical Care Unit Monitoring and Hemodynamic Goals. And here is the only paragraph I found there actually describing hemodynamic goals in management of cardiogenic shock. The optimal map likely differs from patient to patient, and the risks of hypoperfusion with lower maps must be balanced and individualized with the potentially deleterious impact of vasoactive agents. While it is certainly quite prudent and appropriate, it doesn't give very specific goals for management of cardiogenic shock. But we all know that we typically target mean arterial pressure 65 and above, so I started digging where it is coming from. So basically, all the recommendations for goals, hemodynamic goals in shock, are coming from the studies in septic shock. So I went to the guidelines on septic shock, and the contrast was striking in the clarity and specificity of recommendations. Reading from Surviving Sepsis International Guidelines, hemodynamic goals, CVP 8 to 12, MAP greater than 65, mixed venous saturation greater than 65, normalized lactate, urine output. Where is it coming from? They're referenced. This is the source, one of them. In-hospital mortality was 30.5 with goal-directed therapy, with exactly this goal-directed therapy, with these goals in randomized controlled trial, versus 46.5 with standard therapy, not goal-directed. And the difference, as you see, is enormous, and you understand why it made it all the way to the guidelines. Speaking about mean arterial pressure greater than 65, what's interesting, and again, this is coming from the septic shock. When they divided all the maps, all the range from 70 to 100 into quartiles, they got exactly similar mortality with all quartiles of mean arterial pressure. But when they put the quartiles of vasopressor load, vasopressor dose, with each increase in quartile, they have stepwise increase in mortality. That's where this recommendation is coming from. Don't overdo with vasopressors. So it is also coming from the literature on septic shock. Best results were seen with a map between 60 and 65. The time spent below these values correlated with the risk of mortality. Map less than 60 increased the risk of death with odds ratio of 2.96. So clearly it made it in the guidelines. But hemodynamically, septic shock and cardiogenic shock are completely different. Yes, they both share the same feature, and organ hypoperfusion, tissue hypoperfusion. That's why it is all shock. But otherwise, cardiac output increased in septic shock, decreased in cardiogenic shock. Wedge is normal in septic shock, increased in cardiogenic shock, and so on. So hemodynamically, it is completely different entities. So we should not just copy and paste the hemodynamic goals to septic shock into the cardiogenic shock setting. So cardiogenic shocks, as you heard before, are not created equal. There can be cardiogenic shock because of pulmonary embolism and acute right ventricular failure with underfilled left ventricle, and this underfilled left ventricle creates low cardiac output. It can be acute myocardial infarction with left ventricular failure, high wedge, and normal right atrial pressure. They both have decreased cardiac index. So the goals probably should be similar in terms of cardiac index, but they should be different in terms of central venous pressure. They probably should be different in terms of wedge pressure. And yes, we need prospective studies, like Nir was saying in the comments to the prior talk. There is also difference, how do they get to cardiogenic shock, depending on what was the etiology of cardiogenic shock. If it was MI-related cardiogenic shock, if it is 45-year-old man who played basketball yesterday, then this immediate impact of LAD occlusion creates decreased cardiac output, hypotension, hypoperfusion, and then perhaps congestion. While in heart failure-derived cardiogenic shock, people existed with congestion for months or years, and decreased cardiac output might not be an overnight, but a gradual event. And then hypotension comes, and then hypoperfusion comes. So again, our goals or priorities of these goals may be different depending on what variety of cardiogenic shock hemodynamically we are dealing with. Congestion is a separate question. There is different profile on mortality depending on the type of congestion. It can be right ventricular congestion, left ventricular congestion. It can be biventricular congestion. And what you see here, the first set of gray bars is all comers with cardiogenic shock. And you see that right ventricular or biventricular congestion carries much higher mortality risk than left ventricular congestion. And then you have green bars with the myocardial infarction-induced cardiogenic shock. And then heart failure-induced cardiogenic shock with blue bars. And again, you see that left ventricular-related congestion carries much higher risk of mortality with acute myocardial infarction than with heart failure-related cardiogenic shock. Understandably, acute pulmonary edema in completely unprepared cardiovascular system, and there is a shock state. So I believe our common goal for the years to come is to bring the status of the guidelines in terms of goal-directed management of cardiogenic shock from the current state to approximately the state of clarity and specificity the septic shock guidelines currently have. And for this, we need prospective studies comparing different sets of goals. So our criteria for cardiogenic shock, low cardiac output, right? Because it results from inadequate cardiac output requiring pharmacologic or mechanical circulatory support. So the goal is adequate cardiac output, and this may be one size fits all. I don't know, but maybe. Systolic blood pressure less than 90. We don't even go by mean, we go by systolic, so we need to provide adequate perfusion, and what kind of blood pressure we need for this, we have to figure out. Wedge greater than 15, so we need to achieve euvolemia, and again, this euvolemic goal may be different for right ventricular versus left ventricular originating cardiogenic shock. And that's all. I was afraid that it will forward me to my beautiful Methodist hospital, but it did not. So I made it on time.
Any question, Manish?
So thank you so much for that talk. That was great. I think one area that'd be interesting to kind of expound on is the idea of having MAP as a goal. I think when we look at it in the setting of surviving sepsis, Dr. Rivers, which by the way, I think that was a 3-physician to 1-patient protocol where they were able to show that level of significance, which I think we could do with that resources. But specifically when we look at MAP, what we're really thinking about, I think in my perspective, is oxygen debt and oxygen deficit in the setting of cardiogenic shock. MAP is not a surrogate marker of that. Was in the setting of essentially not having total vascular resistance and sepsis, but with the inability for the heart to meet the demands of the body, the blood pressure, I think, is a questionable idea, and there's been enough data out there to question whether vasopressors, inotropes, and their utility in relation to MAP versus contractility is a difference. If we have somebody with a systolic of 50, a systolic of 70, a systolic of 90, but no oxygen debt by surrogate markers, how do we protocolize that? Because I think that becomes difficult if we're trying to transition in that protocol.
That's a very astute comment. And of course, we have to take into account what was the patient like before he went into cardiogenic shock. Like if they're a pressure from one office visit to another was 85 to 90, and they were perfusing fine. Like, I don't know what you guys do, but I often tell my intensivist, like, there is a great increased requirement in presses. And I was like, his blood pressure is usually 90, so why don't we lower the goal from 65 to 55 and see if we can come down on presses? If he's still maintaining and he's still making good urine, maybe this is enough. Maybe we don't have to struggle for 65. But it is individual. So far, we don't have any goals directing us. So that's we as a field have to create.
You know, another quick comment is, I'll wear the hat of the coronary guy. You know, if you have, to nearest point, a swan in, to me, you know, with all the equations we would always think about in the unit, it's coronary perfusion pressure, mean arterial pressure minus the wedge. That's what we live by. So, you know, if somebody's really volume down, you want to deal with that versus if someone's really volume up. You want to sort of maintain that. So this sort of number of mean arterial pressure to me always seemed this artifactual thing. And as we move to this era of precision medicine, I think we need ways to think about that. You know, if a patient has coronary disease versus non-coronary disease, you want to make sure you have adequate perfusion of the coronaries, because otherwise, you know, you're going to be out. And I think about congestion with interstitial pressure and other things. We don't have a way to measure that, you know, collapse of the vessels, but coronary perfusion pressure is a very easy way to always think about what is the adequate pressure in that setting for that patient if you have a swan.
And perhaps this should be the goal. I don't know, but it makes sense, maybe.
So just, you know, when we trying to put number, we said we have to be with a map above 65. We have to be there. I think we sometimes simplify a very complex topic.
Yeah.
Why we don't think about what is actually perfusion? Because that's the bottom line. We want to take a patient out of shock. The shock is not what is his blood pressure. The shock is what happened to the periphery, to the perfusion. We want to make sure that the kidneys get enough blood, the liver get enough blood, the brain get enough blood. And that's the reason I think the challenge with cardiogenic shock compared to septic shock. Septic shock is a very different etiology. You have a vasodilatation that after due to cytokine and liposaccharide that is actually increasing the vasodilatation process. Here, I can do some blood pressure now on young people here in the audience, and they will have a cardiogenic shock blood pressure map. Doesn't mean that I need to give all of them levofed in order to make the map above 65, and then let their heart work harder.
Near, not when you're talking, their pressure will be up.
Yeah, exactly. So what I'm saying is, I do think that I'm not so sure we will get in the end to the same clarity of septic. We will get to the end in something clarity about perfusion, or actually, going back to Jason Katz's talk, the phenotype of actually the metabolic alteration derived from cardiogenic shock.
I think also, maybe from the septic literature, you know, you showed the New England Journal paper from Manny Rivers from 2001. It was my understanding, actually, that 3 prospective trials showed that goal-directed therapy did not actually work in septic shock. So I think that points out the danger of, I think a little bit to Nir's point of, and some of the hesitancy of generating these algorithms and putting hard numbers on them. So, you know, it's incredibly, I mean, if we're going to argue about every single number, right, you know, and in your chart, you didn't include CVP, yet in the cardiogenic shock working group, we saw that was an extremely powerful metric of mortality, and it's something that we do not aggressively address, I think, in the clinic.
The problem with the goal-directed therapy is because we don't know where the goalposts are. We need to know where the goalposts are, and the goalpost, like Yuri said, is perfusion.
Yeah.
Right. It's not the rest of it, how you get to that perfusion. Doesn't matter what the cardiogenic shock phenotype is. If you go to an ICU and the patient's making urine and his lactates are coming down, I wouldn't change anything. The patient's doing fine.
Agree.
We have some comments here.
Could you guys show my last slide once again, please? Not the hospital, but the prior one.
Thank you. Ali?
Goals for the particular patient. We're not 60 or 65 will not fit all patients. Exactly. And I think as Nir mentioned and Mark, that's perfusion is an important thing. But what's important for us now, patient, we accepting such kind of low pressures on them. which kinds of parameter we have to look to them to be sure that the patient is doing okay with that, with this low pressure. If I'm accepting 55, how are I going to teach the resident and fellow say, look to what? We're looking to the lactic acid, mental status. Sometimes urine output's is not a good marker because they are on CRRT. We have to see what kind of safety measures we have to look to prevent bad things from happening from a patient. We accepting blood pressure of 55 on them and try to impress based on that. But individualized, we have to look to that, and it is always more demanding because you're looking to, pushing us to look to the etiology. If it's coronary artery disease or some other things, we might accept different approaches and different pressures for the particular patient. Patient have hypertension before in the past, I would not keep him to go from blood pressure, was living uncontrolled blood pressure and coming to the ICU, probably that 65 might be low for him or her. That's how it is individualized. But we have to put for safety measures for us to prevent bad things happening from accepting such kind of suboptimal or lower blood pressures.
The audiovisual guys, could I please have the last slide? We have still 1 minute of discussion.
David?
So a really, really nice talk, but I think the problem is that we're all expecting what can't be. We all want to have patients where you have a specific guideline, you have the rules of the game, but there's a million different games as much as there's a million different patients. Really what you need is serial observation, which is the hardest thing. We all have the experience. You go home at 7, 8 o'clock at night, and then it's like the wolves howling, and you come back in the morning and what happened? Because serial observation is the hardest thing to do. It's hardest to train people and to have somebody available. Then you'll always win because every patient is their own equation. And though it's nice to have specific goals, the goal is keep watching, watch and see what happens. And that's unfortunately difficult, hard to put in writing, and very hard even more to convince people to do it, especially at various times of the day.
Duty hours have undermined
Thanks,
that.
David. So, to address Daniel's and Nir's comments, that's why I put here our goals for cardiogenic shock management: adequate cardiac output, adequate perfusion, euvolemia. And we need to figure out what is it for each subset of cardiogenic shock. And yes, I completely agree that we may not be able to come with exact set of numbers or ranges, but at least it will give us some direction where to go in different hemodynamic subtypes of cardiogenic shock.
Thank you.
Thank you.